Hello, everyone. I'm Dr. Norm Zarsky, coming to you from snowy Massachusetts. This is a picture of me and my terrific, lovely wife, and that's Boston Harbor with the city behind. Many of you, of course, will be familiar with this. We were hoping that we would be able to come and join you in Abu Dhabi, and we almost made it. And then, of course, the latest surge came, and we decided it was a better part of valor not to fly to you. So I'm very pleased to be able to join you in this electronic fashion, and I have a topic which I hope is of interest and useful to you, based on my experience of consulting and participating in primary care clinics and geriatric settings. Now, the picture here is not really topical, but it was beautiful, and I thought I'd share it with you. There's an old saying that if you want to teach something, that you should tell people what you want them to learn, then you present what you want them to learn, and then you summarize what hopefully people have learned. And so we're going to try to follow that model. Let's talk about bipolar patients in primary care practices. I know that this is not a simple topic for a lot of people, because bipolar disorder, I think, is really not well taught in our, at least in the US, in our medical school teaching, and not terribly well in residency teaching. Even in psychiatry, I think it's underappreciated and not well taught. So there's plenty of bipolar people out there. And the question is, are there unrecognized bipolar patients in my practice? Well, there are a lot of unrecognized bipolar people. Here is the young Winston Churchill, rather handsome and dashing fellow. And as his life progressed, it has become clear he had symptoms of bipolar disorder, including how he recorded in his diary, which he was apparently quite attentive to, every time that he woke up in the morning in a crushing depression, he would say, "The black dog is upon me." So we have a chart of his mood cycling, I think, in his diary. So he's certainly not alone. There are plenty of other people. Here we have Beethoven, who was apparently quite subject to significant mood swings and disorder. For those of you who have an interest in US history, this is a historically inaccurate portrayal of our president from the early 1900s, Theodore Roosevelt. And he was famous for his combat in the United States war over Cuba with Spain, the Spanish-American War. And this is not how it happened, but it's a great propaganda piece. But later in life, this is what he looked like. And you can see a fair amount of the energy and force behind the man, for which he is famous. And retrospectively, it appears that he was probably bipolar. So that means you have bipolar people in your practice. The statistics are that something like 3 to 4% of people worldwide have bipolar disorder of some sort. Bipolar disorder is a spectrum. It's not the same presentation of disorder in everybody. These people's illness is often unrecognized, and apparently there's a fair amount of evidence that it takes about 10 years of contact with the medical system for some bipolar people to be properly diagnosed. So isn't it sort of obvious when people have mania? I mean, won't you hear about that, or won't you see it in the clinic? especially the way most of us learn about mania, which is that it's really quite an event. Well, you may confront this in the waiting room, but in primary care clinics, generally, you don't see demonstrable manic behavior. The people who have major bouts of mania have been recognized, and we'll speak to that before. That's an unmistakable clinical syndrome, and generally those people have been in the hospital. So, do people come into the primary care clinic and say, "Doctor, I'm bipolar"? Generally not. And even in psychiatric clinics, there isn't much of that, unless someone walks in as the first patient I made this diagnosis for, who said, "Oh, I'm here because my father has been diagnosed bipolar, and I realize I am too, and I want to try some lithium." That was a rare event. So, the point we want to make to you folks today is that bipolar disorder in the primary care clinic presents not with mania or hypomania, not quite all the way to full mania. It presents with a chief complaint of depression. And starting with the theme of saying it, repeating it, and saying it again, the clinical clues that will help you figure this out are mood cycling, hypomania, and thought disorder. These are the things we're going to discuss going forward. So this is a magnificent, huge tornado, fantastic picture, and I think it is a reasonable analogy to a full-blown manic episode. No one will fail to notice a tornado. And so if people have type 1 bipolar disorder, meaning that their elevated mood state is a full-blown mania, then everybody's going to know. This is not mysterious. But what about the people who don't have that full manic syndrome, who have a hypomanic syndrome, who have an attenuated set of manic symptoms, who don't end up in the hospital, who remain functional in the community? What are the clues to their problem? And here you have a dust devil. It's a small tornadic windstorm that doesn't come from the sky. It comes from the earth, as it were. And it's quite troublesome, but not in the proportion of a huge tornado. So we make the point here that people in the community who have bipolar type 2, which is that they have hypomanic episodes, tend to have what they call rapid cycling. They have more than 4 episodes in a year, and the episodes of mood disorder are relatively brief. The hypomanias tend to run 2 to 3 days. So people won't come in and say, "Doctor, I have hypomania. I have periods of time when I'm really energetic, when I don't need to sleep much, when I make big plans, when I take risky actions, when I spend too much money, when I get really brilliant and think that I'm doing great, that amuse people with my amazing humor, that I talk too fast, and so forth." They don't tell you that. And they generally don't come in complaining of the usual bipolar 2 depressive episodes, which are very typically 5 or 6 day episodes of depression. And of course, not all people with bipolar disorder have this exact scheme, but this is so common that it's worth using it as a sort of template for the conversation. So they may be in your practice for a long, long time, and you never hear them say anything about their mood symptoms. And they don't complain of how changeable their moods are, although sometimes their families might, but they tend to keep that private. They don't talk about the dramatic mood changes, which may be disabling to a certain extent, but which they've mostly learned how to accommodate in their lives so that they can function. So why don't they tell you these things? Now here we have a brief nod to telemedicine, which is our present and may be our future. Well, number one, many times people don't understand that they have a mood disorder. They are aware that their moods are problematic for them, but they mostly don't discuss it, and they don't generally reveal it to strangers or doctors. Sometimes it's because they think it's going to get better, or if they just hold on, things will change. They may feel like, well, other people must have this too. I'm not abnormal. This is just part of the normal variance. Or they might feel this is them being terribly, terribly ill and terribly flawed, and it's shameful, and they don't bring it up. So you may not hear about this for a long, long time. But if you eventually hear about this in the primary care setting, what causes the patient to bring this to you? The answer is that they come in when the familiar pattern of ups and downs is disrupted. And when that happens, it's usually because they end up in a much longer depressive episode than they're used to. For many people with this disorder, they tend to have about 5 days of depression in a given month or 6-week period, and 2 days of hypomania. And they can live with that. They sort of expect that. And when they are in the depressive episode, they grit their teeth and survive, knowing that it will abate in a few days. However, sometimes that doesn't happen. Sometimes the cycling event at the end of the depression doesn't come. So then people are really in trouble, and they might come into the clinic and say, I need help. And they almost always say, this is the longest and worst episode of depression in my entire life. And that's because it is. It's a terrible event. It's a very hard illness. Okay. So we'll just make the point here that bipolar depressions, whether they're brief or long, are generally rather severe and emotionally painful and functionally impairing, and often include suicidal thinking, if not planning for suicide or planning to die, at least morbid thinking and thinking how people ought to be dead or maybe they should kill themselves. And when such a person is in the clinic, it's really quite alarming. And between all the people who interact with this patient in the primary care clinic, it's likely that people are going to get pretty alarmed. And in primary care, of course, you don't have a whole lot of time to figure things out, to make a plan, make a disposition. And so it's not surprising that in the face of such a severe depressive presentation, people receive a prescription for an antidepressant. Now, also, it's probable that it will not become clear that this is a bipolar event. Why? Because we don't teach this very well in psychiatry or in general medicine, and because there really isn't a whole lot of time, and screening takes a little bit of time. So one of the things that I hope you'll come away with is the thought that it probably makes sense to do a little bit of screening when depressed patients come into the clinic. But let's put that aside for the moment. So what's the problem when you give your patient an antidepressant? Well, there's a series of problems, including the fact that for the most part, antidepressants don't work when used alone in a bipolar depressed patient. And even in psychiatric circles, it's quite controversial about whether one should use them at all, or if one should use them for a very limited period, or if one should use them in conjunction with a mood stabilizer that you know is helpful to the patient. So when prescribed alone, generally they don't work. Now, don't be fooled, because sometimes your patient will come back all better, but it may not be because by the next visit they've had a pharmacologic response to their antidepressant. It may be that they finally had the mood cycling event that they've been waiting for, and that might have ended their depressive episode. Another problem, antidepressants may, as people say, flip the switch to mania or hypomania. It may have such a profound effect on their mood regulation that they progress in a mood cycle under the influence of the medicine to a manic or hypomanic condition. But here's the thing that I think is not all that well known. There's good evidence that use of antidepressants in bipolar patients has a tendency to make the pattern of their mood cycling worse. And we're going to talk a little more about mood cycling in a moment, but it can have the effect on their mood disorder that living a long life with mood disorder has, which is that over time, people tend to have increased frequency of mood episodes and increased severity of mood episodes. So unfortunately, antidepressants can move the natural history of the disease into a more stormy and difficult period. Now, another issue to point out is that once one antidepressant seems to fail, then people will end up on another antidepressant. And many of these people have a relatively long history of either, partially or completely unhelpful exposure to antidepressants, with the unhappy result of changing the natural history of their disorder. Okay, now this slide doesn't say a whole lot. It just points out the nomenclature we use. The difference between mania and hypomania is about severity of symptoms. And we just need to point out that even though people have, in bipolar 2, a relatively brief depressive episodes, it can be incredibly painful and very powerful, essentially as bad as people who have bipolar 1 depressive episodes. Now, I don't need to review this in detail, really, because this is the sort of thing that people have good exposure to. It's a reminder of the symptoms of major depression, which probably, it's something that you ask people all the time. And this is not a hard reminder to find. And this is the mnemonic which is frequently used to talk about what mania is. So again, not hard to find this, but distractibility, sleep deficit, indiscretion toward pleasure, grandiose ideas, flight of ideas and other thought disorder, increased goal-directed activity, problems with sleep, and partial speech. These are things that if a person comes into your office displaying this, you will know to say, holy Moses, this is probably mania. Okay, so now we're ready to make the proper diagnosis, right? Well, in the beginning, we reminded ourselves that we have to talk not only about hypomania and depression, but also about mood cycling and thought disorder. So let's talk about what this is. To be able to make a confident diagnosis of a bipolar condition, you have to know that the patient displays autonomous mood cycling. Now, autonomous means that it isn't just reactive to life events. It isn't just because something good happened or something bad happened or some conflict took place in their emotional life. Sometimes, and usually frequently, it happens absolutely unpredictably. And the other thing is that they have to have, when they are hypomanic and in their high energy mood state, they have to have disruption in the quality and structure of their thinking, meaning they have to have thought disorder. Mood cycling is everywhere. So let's just make the point. Mood cycles refer to the fact that there are different stages of mood which are experienced by people with bipolar disorder. And they go at some level from hypomania to depression or vice versa. Sometimes these things follow right after the other, and sometimes they happen with days or weeks between them. And sometimes a mood swing doesn't seem to be triggered by some stress in their lives. And thus it's an autonomous mood cycle or mood swing. A thought disorder really is everywhere because it's certainly not just a symptom of bipolar disorder. It's not just a symptom of hypomania. It's a symptom of a lot of disorders where psychosis is part of the picture. So reminding again that if you don't get a history, which is comfortably a history of hypomania, you can't say the person's bipolar. They may be agitated, or they may be talking fast, or they may be thinking fast for some other reason, be it substance abuse, be it anxiety. But if they don't have distorted thinking, then you can't say it's hypomania. And this is a representation of how jumbled up and crowded people experience their thinking when they're hypomanic, at least at the higher, most powerful parts of that syndrome. Okay, so this is worth actually spending a moment on. What does it mean to have thought disorder? Well, there's difficulty focusing. People tend to ramble. Their thoughts jump from one idea or a story to another, to the point of sometimes being incoherent. They come up with ideas in sequence which have little or no logical connection that you can't tell the difference. So a person may be talking about one logical issue in their current life, and then the next thing immediately is a discussion of something where you have no sense about why that topic came up. Sometimes they're frankly psychotic and have auditory or visual hallucinations, and not infrequently, they're at least suspicious, if not actually paranoid. And you will notice the oddness of their affect. They look flat sometimes, they're not making good eye contact. It's clear that they're accelerated, and they may be doing things which are evidence of incredibly poor judgment. Now, one other point to briefly make is that not all bipolar episodes are clearly manic or hypomanic, and not all bipolar episodes are clearly depressive. But some people have what we call mixed presentation or mixed states. And that can get quite confusing diagnostically. In general, we're familiar with the idea of an agitated depression, which is that someone has severe depression and incredible amount of internal tension and agitation. Sometimes it's external agitation. Sometimes people can't stop moving. That's really a mixed state. And in bipolar 2 people whom you may see in the office, generally they come in and at first glance they're depressed because they have depressed mood, they feel terrible, they may be suicidal. It really, it's demonstrably a symptom of depression. Except when you look a little closer, you may find the agitation, the thought disorder, the sleep disorder, the overactivity. And in that case, you have discovered a mixed presentation. And treatment of the mania predominates. You have to treat that first. So now we have a little bit more time and we want to make sure that you're awake. So I'd like to go over some of the things that I ask people in the office that might be helpful for you to hear in order to screen for the possibility that this depressed person is actually a bipolar person. And you won't be surprised, you're looking for hypomania in the history, you're looking for mood cycling, autonomous mood shifts or mood swings, and thought disorder. Okay, so I have about 5 minutes. You ask about hypomania. Do you ever experience a mood state which you would call the opposite of depression? I put it that way because mania is a buzzword for many people, so I try to avoid too many medical terms. And they might say, well, what do you mean? And then you say, well, I generally ask them about their energy state. I don't ask them about euphoria because manic people are often not euphoric or not purely euphoric. They switch in and out between euphoria and irritability and anger. That's dysphoric mania. So euphoria and dysphoria are not stable for most people. So if you say, do you ever get euphoric? You may get a no. So I tend to ask about elevated energy. And then a little bit of detail to see if we can recognize a pattern like a bipolar 2. How long do the high energy times last? Do they come on suddenly? Do they come on sometimes overnight, where you wake up in this markedly different mood state? Because that is a cardinal sign that this is a bipolar condition. Or do they start insidiously? The start of a mood episode which comes on over weeks is generally not something that happens in bipolar disorder. And how do they stop? Do people cycle out? Do you wake up one morning at the other end and say, oh, the black dog is gone, I'm better now? Or do they take a long, slow recovery? Do people notice? Do you turn from being in excellent humor to being very irritable? We're looking for thought disorder. Is there a change in the speed of your thought process? I never say, do you have racing thoughts? Racing thoughts is a buzzword, at least in our populations, and they think they know what you mean. So you have to ask just about the velocity of thought. If your thoughts speed up, do they sometimes get mixed up, disorganized, or do you get lost in a sea of different thoughts? And do you get suspicious or fearful? Again, I try to avoid the word paranoid. In your high energy sleep, does your sleep change? Can you be effective? Are you able to get things done? Or do you get to the point where even though you have the energy and you have motivation and you want to do stuff, you just can't logically apply yourself to the task? You make plans, start ambitious projects, and then abandon them, so forth. Spend a lot of money. Okay, and briefly about the depression, How long do these periods last? Is this a person who has the typical bipolar 2, 5 or 6 days of being depressed? Do they have mood cycling to enter this depression, as we said? Do they cycle out of it? Do they have slowing of their thoughts when they're depressed? That's frequent finding in bipolar people. Another sort of soft sign is, does your body feel like lead? Is it hard for you to raise your arm? Are you just exhausted? And do you think about being dead or killing yourself? All right. Now, another thing to keep in mind is that there's a correlation between bipolar disorder and alcohol abuse and other substance abuse as well. And it's always good to ask if there's somebody in the family who has a mood disorder. And this, of course, you use your best language to ask in a sort of non-medical way. Okay, so we're coming to the end. Treatment is really not the topic for today, given the time allotted, and it's a complex one. Antipsychotic drugs have a role. Anticonvulsant medications, which have entered our pharmacopoeia as mood stabilizers, are definitely a factor. Lithium is indeed a factor, and this old advertisement from the late 1800s is just to point out that lithium didn't just suddenly appear in the 1960s in Australia as something that people should take for their health. Okay, well, this is a bit of a romp through the topic, but it's certainly been a great thing for me to spend the time preparing this and thinking about it, and for a while being excited about coming to Abu Dhabi. But this is something that, if you keep mindful, you are likely to see in your primary care practice. So remember to look for hypomania, mood cycling, and thought disorder. Thank you very much. Thank you for indulging my love of old-time flying boats. Maybe next year we'll be in the air heading your way. Thanks a lot.